chatting. All right. Good morning, Facebook. Now both cameras are on and we can get rolling. So for those of you who don't know me, my name is Morgan Denny. I am lead faculty for ICE's Primary Care Physical Therapy Division. And you are listening to the PT on ICE Daily Show. So welcome to your Tuesday. I'm here in Portland, Oregon, where we have not burned down yet. We got close. But if you notice that my eyes are a little bit red, or that my throat is a little bit scratchy, please excuse that. We have been living in a smoke-ridden environment with a air quality index over 500 for approximately 5 days now. So working on resolving all that, but apologies if I get a little scratchy in there. So today we are going to talk a little bit about COVID-19 and some of the heart effects that we are seeing in the research that are coming out of that. And apologies, I'm going to be looking over at this sheet because I do want to get all my numbers correct for you who will go and look at this research because it is really good research to check. So basically today we're going to talk about heart injury. Now I know that COVID-19 is kind of a respiratory illness and many of you are thinking, respiratory, I thought it was, or cardiac, I thought it was lungs. Like, what is she talking about? So as COVID-19 goes on and we start to learn more and more about it, we're finding that there is additional cardiac injury that comes with many COVID cases, even though we think of it as primarily a respiratory type of disease. So we're going to start looking at some of those things today because luckily for us, JAMA put out an article a couple of months ago out of Frankfurt that really looks at a small cohort, but yet a very beginning step of us understanding what's going on here. Now, why, you may ask, like, why do we really need to know this? Like, we hear about COVID, but we're not really seeing these patients in the clinic. And I would say that should come with a ... yet. You're not seeing them yet. Because if you start looking at the numbers, not only have 195,000 people died of COVID infection in the United States thus far, but 6.57 million have now been diagnosed with a positive test. And we know that number is low because we know there are a lot of asymptomatic people who never get tested, who are walking around. We know the testing's not great, so there's probably some people who are positive for COVID-19 who have had a negative test but are actually positive. So the number is probably higher than 6.5 million. Now, if you get tricky and you do the math, there are 328 million people-ish in the United States. If 6.5 million of those cases, 6.5 million people have been positive, that means that 1 in every 54 people in the United States has now had a positive COVID test. 1 in 54. That means that the probability that you know someone who's had COVID is pretty high. That also means that the probability that you are going to have someone in clinic who has had a positive COVID test is pretty high, and also is going to go up as we move forward in time. So lucky for us, this study came out. So this article out of JAMA is called Outcomes of Cardiovascular Magnetic Resonance Imaging in Patients Recently Recovered from Coronavirus Disease 2019, aka COVID-19, you guessed it. So what they did is they took 100 people in Frankfurt, because that's where they are, between April and June who had had a positive COVID diagnosis via the brain swab and basically had already recovered. So they were required to have had 2 weeks of recovery, but most of them actually had had their diagnosis long before or months before with a full recovery. But they did this independent of asking about timeline. So they're trying to figure out, are there demographics within that subset, within the population, that basically have greater injury of the heart or any at all? Because again, this is a really new disease. We're just learning about it. We're just starting to study it and figure out what we actually need to be looking at. So in this population, in their control group, luckily they chose 100 people, which means that our statistics are really simple and our numbers and our percentages are pretty easy to figure out. So within that, they looked at demographics, of course, cardiac blood markers, and they did an MRI of the heart, CMR. They also had a control group, which was age-matched, sex-matched, which is really important because men and women suffer from COVID differently, or at least men die at a higher rate of COVID than women do. They also had a risk factor matched control group, which was awesome because we think about COVID and we think like only if you have diabetes, only if you have cardiovascular disease, only if you're obese. So they took that and they made sure that they had a control group that actually matched their research group in terms of some of those pre-existing conditions and those other risk factors. Within this group, half of the participants were men and half were women. It was like 49-51, so pretty split down the middle. And of those, 67% recovered at home, while 33% were hospitalized. So about 2/3 convalesced at home, and 1/3 were in the hospital for their COVID recovery. Now, some of them, so about 20-25, did have those underlying conditions like COPD, diabetes, obesity. But if you look at the average blood pressure of the people who were in the research group and the control group, it was actually very similar. Within the research group, it was 129/80, so high, but not off the charts high. The resting heart rate was 67. So it was super close to controls. The controls were like around 122/75 with a resting heart rate of 64. So pretty close if you're looking at vital signs. So we're looking at two groups of people, like the controls are very well matched, I guess is what I'm going to point out here, so that we don't think like there could have been some other interaction, right? The controls are very well matched. So the results of this study, when they did an MRI of the heart and they looked at these cardiac blood markers, I'm going to give you the punchline first. Cardiac involvement in 78 patients, that's 78%, and ongoing myocardial inflammation in 60% of the people that had recent COVID-19 illness. This was independent of pre-existing conditions, severity, and overall course of the acute illness and the time from the original diagnosis. Meaning, what they found from a heart perspective had nothing to do with how long it had been since this person was diagnosed. So the people who had been diagnosed a month ago versus the people who had been diagnosed about 3 months ago, no significant difference. So timeline and that healing pattern, at least within these early acute phases, was no different. So we need to keep that in mind, right? That people that have had a COVID diagnosis, independent of severity, independent of timeline, may still have these underlying heart conditions. Now, let's get into a little bit of the nitty-gritty for those of you who like to nerd out like I do. So, all right. So in those patients, let's see. So of those patients, here's another tidbit. A chunk of them, 36%, still reported ongoing shortness of breath and heart palpitations. So, and some of the other things that like we think of as more common elements of COVID, even though people were far out of their illness, a lot of them still reported having some of these aspects that we do think about as normal COVID symptoms on the day that they got their heart MRI, their CMR. At the time of CMR, this is where we get really nerdy, high sensitivity troponin T was detectable in 71 patients, 71%, and it was significantly elevated in 5%. So for those of you who don't know what high sensitivity troponin T means, because I didn't, had to Google it, that's cool because the internet's fun, this actually indicates heart muscle damage or heart attack, right? So this is something they measure if they're looking at cardiac injury, generally speaking. So that's 71% of people who have had COVID, again, independent of any of these comorbidities or timeline, had some kind of heart damage and a blood marker that shows up for it, this high sensitivity troponin T. They also had lower left ventricular ejection fraction, higher left ventricular volumes, and raised native T1 and T2. All of these are basically signs of kind of a dysfunctional heart. So the ventricular contractions were a little bit slow. The filling rate was overdone without a good ejection fraction. The T1 and T2 kind of look at the native T1 and T2, look at some forms of inflammation around the heart, kind of like you'd see in pericarditis. And in this study, if you look it up, it's pretty cool because, you know, I'm a nerd. So it's pretty cool though. It shows some of the imaging examples from patients. And you can totally tell with a fairly untrained eye, or if you've looked at a few MRIs, and see some of that native T1 and T2 around the sac of the heart that is there residually for patients who have had COVID. You can also see some of the histological changes that they're talking about in terms of the troponin levels and in terms of that scar tissue. So again, remembering that like when we see patients in clinic that have had COVID-19, independent of symptoms or severity or how long ago it was, we need to start thinking these people may have heart injury, not even have had at this point. It's these people may have ongoing heart inflammation similar to a pericarditis, and we need to start thinking along these lines if we want to be safe with these patients. Okay, so I'm going to read you directly a couple of quotes from the discussion because I believe the authors put this very, very well and very succinctly. So they said a total of 78 patients who recovered from COVID-19 infection, again 78%, had cardiovascular involvement as detected by standardized CMR, irrespective of pre-existing conditions, the severity and overall course of the COVID-19 presentation, and also independent from the time from the original diagnosis or the presence of cardiac symptoms. The most prevalent abnormality was myocardial inflammation, defined as abnormal native T1 and T2 measures, detected in 60 patients recently recovered, followed by regional scar and pericardial enhancement. The results of our study provide important insights into the prevalence of cardiovascular involvement in the early convalescent stage. Again, we don't have research that shows anything long-term because we're still here in the beginning. Our findings demonstrate that participants with a relative paucity of pre-existing cardiovascular conditions and with mostly home-based recovery had frequent cardiac inflammatory involvement, which was similar to the hospitalized subgroups with regards to severity and extent. Our findings reveal that significant cardiac involvement occurs independently of the severity of original presentation and persists beyond the acute presentation, with no significant trend towards reduction of imaging or serological findings during the recovery period. Our findings also provide an indication of potentially considerable burden of inflammatory disease in a large and growing part of the population. Now, I think that last piece is really key. So as the authors point out, we don't know if this lasts, further than these 3 months initially, because that's kind of what we've got right now. But what we need to realize is that in a large part of our population, again, right now we think it's about 6.5 million who have been diagnosed with COVID-19, we could have an inflammatory heart condition going on that could last, and it could be independent of people having any symptoms or knowing that it's there. So we as medical practitioners need to start bringing up this idea in our mind, need to start asking our patients the question, right? Because we don't know if we don't ask. So when we have patients who are new, who are there for an eval, or who've been gone for a while even, really being straightforward and saying, hey, have you had a positive COVID test? I'm not judging you. I'm not going to tell you to go home. I'm not going to, cry for you. I just need to know, have you had a positive test? And then some questions following that go with their symptoms. Because as practitioners, this is really important. Like, what if we find out in 5 years that with this inflammatory heart condition going on, we're prescribing exercise at these high levels and we're actually causing more harm than good? We don't know that yet. There's not research on that type of thing yet post-COVID. But we know that someone with pericarditis, if they came into the clinic, we're probably not going to work them the same way we're going to work someone who does not have a heart condition. So we need to start kind of reeling it in and being a little bit more cautious here and being sure to ask the question. Because you have to realize at this point in time, COVID is still new, but it's going to begin to come with a judgment. People are going to want to not tell people that they've had COVID-19. It's not something that they're going to be like, hey, I'm here because my neck hurts, and also, by the way, I had COVID 2 months ago. That's not what patients do. They only give you the information that they think is pertinent. And someone coming in for orthopedic pain is not necessarily going to perceive that their COVID-19 infection that they had almost no symptoms from, it was like having a cold. They're not going to think that that's actually important to you being able to treat them as a physical therapist. But we need to start asking the question to be sure that we reveal some of these factors, to be certain that we're not being unsafe with patients. Now, what is the recommendation, right? So what do you do if someone comes into the clinic and they have had a positive COVID-19 test? Current recommendations are, if they have had no symptoms, like if they were an asymptomatic case, but they had a positive test, they need to wait a minimum of 2 weeks post-positive test before beginning any type of activity, and then they need to go slowly and be monitored. If you had any symptoms, and we're talking like, oh, I had a little sore throat and a headache and it went away in like 2 days, that is actually considered more severe, and what you need to tell those patients or be working with those patients, is that they wait 2 weeks after symptom resolution. So they need to wait till that headache goes away, till that sore throat goes away, till any of that chest tightness goes away, and then wait 2 weeks, and then begin a slow resumption of any type of activity program. Now, they're also suggesting, and this research now coming out would also suggest, that we probably need to get some kind of cardiac screening for patients who have had COVID-19 who are coming to our clinic if we want to be pushing them at higher cardiac levels or doing any type of endurance training, any type of endurance work to know if we're safe or not. Because we now know, at least with 100 patients, I know small sample size, but we're just getting started here, people. But we need to know when that patient comes in, independent of severity, are we looking at those raised native T1 and T2 levels that show inflammation around the heart? Are we looking at some of that heart muscle damage and significant scarring that might need further healing? We don't know. We just don't know right now. And so we may need to start referring these patients back to their doctor or to a cardiologist or for some kind of cardiac screening in relationship to their positive COVID-19 diagnosis. And if you come up against any feedback, you can use this article in terms of getting patients to get on board with you and getting doctors on board. Because we need to all be thinking preventatively right now because we just don't know what the long-term effects of COVID-19 are, especially on the heart. So we need to start asking this question because as we talked about, 1 in 54 people right now in the United States have been tested positive for COVID. That number is not going to go down, it's only going to go up. So as it goes up, the propensity for us to see someone in clinic who has had any severity of COVID diagnosis and COVID illness is also going to go up. So we need to start thinking about these things and asking our patients, have you had COVID-19? Is this something that you're aware of? And have you had any cardiac screening? If someone was in the hospital, their likelihood of having had cardiac screening is higher. But if they weren't hospitalized, they probably didn't go back and say, hey, you know what, I've been reading the research. I need you to check out the old ticker. Like, that's probably not going to happen. So we, as the doctors of physical therapy, need to start learning more and asking these questions. So jump on that. Now, I will also say, Instagram, you'll have to go to Facebook for this and podcast as well. I made a sheet that asks basically, like, for patients who have had a positive diagnosis, asks a bunch of questions regarding COVID that can kind of get the therapist thinking along the right lines of what and how to treat. But I will post that totally no problem on Facebook so anyone can use it in the clinic. I created it for my clinic, so it's going to say New Heights Physical Therapy, but you put your name on it, whatever, don't care. We need to get safer with these patients. Also, because I always forget to do this at the beginning, we've got upcoming courses, so people check the website, including, if you want to learn more about COVID or lots of underlying medical things, the 8-week online primary care physical therapy course that I teach along with Eric Chaconis. The next cohort of that is starting October 5th, so you've got time to jump in on that. Justin and I will be in Olney, Maryland, teaching spinal manipulation a week from this weekend, and there are tons of other courses that I don't have right in front of me, so I apologize. But you all know, go to ice.physio and you can check out the whole course outline. So before we go, the song of the day, because it feels like this is appropriate where I live right now, is It's the End of the World as We Know It by REM. So give that a listen if you haven't recently, although I'm sure most of us have had it on repeat in our head. And remember, we've got to start asking our patients, have you had a COVID infection, a positive test for a COVID infection, and then regardless of what their symptoms were, their severity, or the timeline right now, we need to be really cardiac sensitive and very aware that some of these things could be on board. Hope that was helpful and hope y'all have a really great Tuesday. See you next time.
Hey, thanks for tuning in to the PT on Ice Daily Show. If you enjoyed this content, head on over to iTunes and leave us a review. And be sure to check us out on Facebook and Instagram at the Institute of Clinical Excellence. If you're interested in getting plugged into more ICE content on a weekly basis while earning CEUs from home, check out our virtual ICE online mentorship program at ptonice.com. While you're there, sign up for our Hump Day Hustling newsletter for a free email every Wednesday morning with our top 5 research articles and social media posts that we think are worth reading. Head over to ptonice.com and scroll to the bottom of the page to sign up.